Hi, this is Jennifer Rahman from Winnipeg, Manitoba, Canada, and I'd like to present to you my typical trabeculectomy with mitomycin C procedure. It starts off by making a bridal suture with a 6/0 vicryl that is placed in the clear cornea around 12 o'clock. This allows you to expose the superior conjunctiva. This suture is being tied, and it will be pulling down the eye inferiorly. You can use a mosquito snap to attach to the drape so that it stays in place. It's just a tie there. Now we can see the superior conjunctiva, and you can note some vessels there. This is a sharp Westcott scissors and a Fechner forceps, which is non-traumatic conjunctival forceps. I'm making a small conjunctival buttonhole incision close to the limbus into the subtenon space. So I'm trying to enter the subtenon space by lifting up the tenons, and there I've gotten down to the sclera. Now I'm using a blunt Simcoe cannula to administer 2% lidocaine non-preserved into the subtenon space, and that is the local anesthesia. I've used a topical lidocaine gel as well prior to prepping. Now we're just going to increase the size of this buttonhole incision and undermine the subtenon space using blunt Westcott scissors this time. And notice that we're using the Fechner forceps, which is a non-traumatic conjunctival forceps. There is a lot of bleeding sometimes in these procedures. So that's why you have to try and stay away from the scleral vessels as much as possible with the blunt Westcott scissors, and try to be as atraumatic as possible. I tend to make a small conjunctival incision so I don't have to close a large incision at the end. We're doing some wet field cautery now with a bipolar forceps. I tend to try and cauterize all the vessels in the area. It is very important not to have a lot of bleeding, because bleeding actually increases the rate of scarring postoperatively and also can change the way mitomycin C works. So we need to make sure that the bleeding is controlled. Often you may get some bleeding in scleral vessels that you can't see, and you have to control them either by increasing the incision size and trying to look for them, or taking a forceps cautery and trying to go after them with a forceps cautery. Now we have pretty much a nice clean area to deal with. It's also important to make sure the limbal vessels are cauterized. Now we're going to make a partial thickness scleral flap, and this is in a trapezoid manner, in a trapezoid shape, I should say. Now I've picked up a 0.12 forceps to grasp the edge of the scleral flap in order to make the final cut here. I don't use this forceps on the conjunctiva, obviously. And so now that I've outlined the flap, I'm going to start the dissection with a with this blue blade, and continue it with a 57 beaver blade. Once you get in a good plane, you stay in that plane, moving slowly forward. It's important to commit to the plane if it's a good plane, and not to come in and out of the plane, thereby making ridges in the dissection. I always feel that ridges contribute to scarring post-operatively. It's nice to have a very flat and plain area to deal with. Now we're putting in some mitomycin C soaked corneal shield sponges. I usually use 3, and you put them in the subtenon space. Push them as far back as you can, and try to ensure that the edges of the sponges don't adhere or touch the edges of the incision as much as possible, so that the mitomycin C is not applied to the wound incision. That can contribute to post-operative wound leak. Now we've waited, usually it's 2 or 3 minutes. In younger patients, I wait 3 minutes. In this case, to be honest, I don't recall how long we waited, but usually if they use a lot of medication and they're younger, there's a high incidence of scarring, therefore we wait 3 minutes. If they have a thin conjunctiva, however, I usually wait 2 minutes for the mitomycin application. Then we remove those sponges, make sure you account for all of them, and rinse with 60 cc's of balanced salt solution, as we're doing here. These are just the 15 cc bottles that you get. I use 4 of them to make 60 cc's. So this is a thorough rinse, and basically there is some mitomycin C present, but it's very dilute at this time by the end of the rinsing. Now we're going to inspect our partial thickness scleral flap. It looks reasonably good. There's still some oozing of blood there we might have to deal with. It looks pretty dry, but there seems to be a little bit of conjunctival oozing there. So just in regards to the corneal shield sponges, I find that they don't fray, and I like them for the fact that they don't fray. Leaving behind pieces of mitomycin soaked sponge is problematic and can cause wound dehiscence and even scleral melt. Now we're just going a little bit forward with the beaver blade and taking the scleral flap dissection a little bit forward, making a paracentesis here. I don't enter the anterior chamber through the flap before mitomycin C is applied. If I do that, I usually don't use mitomycin C. If you enter the anterior chamber through the flap by mistake, you may not want to use you probably shouldn't use mitomycin C, because there would be a high probability of the mitomycin getting into the eye, and then that would be a devastating toxicity to the eye. So here we're just pre-placing the 10-0 nylon sutures, and I usually use either 2 or 3 10-0 nylon sutures to close the flap at the end. I like to pre-place them so I'm ready to close right away once I've entered the anterior chamber. So just trying to save time, putting 2 at a time here. So there is some blood here, but we'll manage that in a second once the sutures are in place. A lot of times when you have oozing from the subtenon space, it usually clears up after the mitomycin C soaked sponges are applied. Here we might have some scleral bed vessels that are kind of oozing. Try to deal with them with the forceps cautery. I usually try the forceps cautery, but you have to be aware that sometimes using the cautery can actually open up the vessels a bit more because the sclera around the vessels shrinks away, and it seems to open up a larger vessel hole. Sometimes you have to actually tie them closed with a 10-0 nylon suture to make sure that they close properly. That seems to have done the trick, however. So we're pretty dry there now. Now it's very important to inspect your Kelly punch before and make sure your instruments are ready. Your Kelly punch, your butterfly scissors, and your tying forceps and your BSS on a syringe. This is the Kelly punch. We've just entered the anterior chamber with the blade. Now the Kelly punch is like opening the ostium. So sometimes we need to do it twice. You have to hold this perpendicular to the sclera to make a good cut. You don't want to have a shelved incision here. You want it to be straight. And as well, when you enter the anterior chamber under the flap, you don't want it to be shelved. You want it to be straight across. Now we've got a little ostium there. You don't need a big one. And now we're going to pull the iris and cut it to create an iridectomy. It's important to be brave and just grab it and pull it out and then cut right across, full thickness right across, so you get a full thickness iridectomy. It doesn't have to be huge, just so that it doesn't allow the iris to pop into the ostium. Now we're gonna, you can see how the chamber shallowed. And we did do the paracentesis prior to entering the anterior chamber, so we are going to refill the chamber in a second. We're just going to close these sutures temporarily to have some control. And you have to do this fairly quickly so you don't leave the AC flat for very long, especially in an elderly patient. And now we're going to refill the chamber. And this patient is phakic, I believe. So now just refilling the chamber. I always like to clean off the blood, if I can, from the edges of the flap to make sure it's kind of clean. You can test the drainage from around the flap with the Wexel sponge, see how loose or how tight you want to leave the sutures. Some people use sort of a slip knot in this part of the surgery. I like to just tie it once and then see how, and then loosen it as needed for a good sort of a slight leakage of fluid around the flap. And then I just finish the tying and then trim the sutures. Postoperatively, you can definitely laser suture lice these sutures to lower the pressure. Some people use use sort of sutures that can be pulled through the cornea. I don't do that particular approach. I use an argon laser suture lysis approach. I use a rich lens with 360 milliwatts of power, 0.1 seconds, and usually takes about 1 to, well, if you're having a bad day, maybe 5 shots, but usually 1 shot in a good position does it, 50 micron spot size, and you can cut these sutures nicely postoperatively. But you have to, usually I wouldn't cut them until about 1 week has passed so that the wound has some integrity before you open it up quickly. Here I was just testing how the flap is draining. Seems to be reasonably leaky. I tend to make my flaps on the tighter side. Post-op early hypotony is difficult to deal with. Often you have to actually go back to the OR to close the flap. If you cut the suture too early, then you have to deal with post-op hypotony often. So it's important to let the wound heal first. Now here we're using a 9/0 vicryl suture on a tapered needle to close the near limbal conjunctival incision. I'm anchoring it at the end of the incision, and this is actually quite a long suture, so we don't need the whole thing. We're just going to attach it to the end here and anchor it basically. And then I'm going to cut the excess off and then just bury the part of the trailing end in the incision itself. This suture basically just degrades and disappears within about 4 to 6 weeks of the surgery. This needle is quite small, as you can see, and rolly, so what you generally have to do is hold it just underneath the round part of the needle to handle it. And this is I'm just going to do a running suture here. And you have to make sure it's even on each side, and evenly spaced, and also evenly spaced from the edges and from each suture. So it's important to cinch as you go along so that you can make sure the entire length of the incision is tight, because sometimes you get to the end and it's difficult to cinch the earlier part of the incision. I'm just cutting off the excess of the trailing end there. You can notice that I grab this needle by the suture first in order to control it, and then grab the needle, just pulling. And again, we're using the Fechner forceps to ensure that we don't traumatize the conjunctiva. Sometimes I put the middle sutures here a little bit tighter, because that's where most of the tension is going to occur in terms of the wound sometimes splaying open post-operatively. So you have to make sure it's quite tight in the center there. It's almost finished. You can appreciate the flap through it. I'm just trying to cinch it closed now, making the final closure here, tying it the suture to itself. I do about 5 throws or so, quite a lot. And then you just want to the reason I do a lot of throws is because this suture tends to slip. I'm just cutting one of the ends kind of short. It'll be hidden and hidden in the rolls of the conjunctiva, and the other just cutting a bit on the longer side so it just folds away. Just testing now. Now you can use fluorescein to test the wound, and you can use that as a strip or 2% fluorescein. Just painted it on there, and now we're just going to test the wound. It looks intact. There's no obvious leakage there. I'm just going to rinse it now. You can also try to refill the chamber and see if it, and stress the wound and see if it opens. That was atropine 1% that we just used there at the end. And that concludes the surgery. We're just going to remove the bridal suture. And I usually use a shield over the eye with some Vigamox and Predfort drops. Thank you very much. I hope you enjoyed this case.